So our next speaker is Dr. Sameera. Dr. Sameera has brought her degree from King Faisal University in Dammam, and she is hematopathology and transfusion medicine consultant and King Faisal University at Dammam. She's the head of the transfusion services, and she's going to take us through the pregnancy-related hemostatic complications. You have 25 minutes of 5 minutes questions at the end.
Thank you so much, Dr. Ranor. Thanks for the organizing committee for inviting me, particularly Dr. Ammar Al-Saghir. So let's get started. Okay. Am I audible? Can anybody give me a hint? Am I audible or not?
Yes,
Doctor. Can I? Okay, thank you very much. So my topic will be about pregnancy-related hemostatic complication, and that's my pleasure to introduce and explore such topic. Here is the outline of my talk. I'll be talking about the hemostatic changes in pregnancy, hemostatic testing, pregnancy-related hemostatic complication, which will be one of these: thrombocytopenia, abnormal hemorrhage, or thrombosis. As you know, in a pregnancy, in fact, all the three factors of Virchow's triad will be affected: the endothelial injury, the hypercoagulability, as well as the venous stasis. And this is related to hormonal changes, the estrogen and progesterone that produce in the pregnant lady. And why that happen? What is the purpose of such hemostatic changes? In fact, it is needed to maintain the circulation from the mother to the fetus, which is very important for the health of the fetus, and also prepare the lady for a very big challenge during delivery. The stoppage of this this amount of blood that flow to the fetus has to be stopped, and this is the purpose of change in the hemostasis. As you know, in a very simple way, the hemostasis, it's just a balance between the procoagulant and anticoagulant factor. But in fact, it is a very complex network of positive and negative feedback loops that integrate the blood vessel, platelet, coagulation inhibitor, as well as fibrinolysis. And this is just one shows you the very complex, it's simplified, but it's still complex, the coagulation system, where you can find the positive and negative loops interact with each other. You can see in a pregnancy, those in red color, these are the factors that will be upregulated, increased, and those in gray will be the one decreased during pregnancy. With the black color, they remain unchanged. Let's summarize these changes that occur during pregnancy, starting with the count of the CBC blood count. The plasma volume will be markedly increased, started in the first trimester, then complete in the second and third trimester. At the same time, the RBC will be increased, RBC mass, but to lesser extent as compared to the plasma volume. And this is why we have a physiological anemia in the pregnancy. Neutrophil count also will be increased during pregnancy, and the platelet will be decreased to a lesser extent, but still within the normal range. Coming to the coagulation factor, as you can see, most of the coagulation factor will be upregulated during a pregnancy, with the exception of factor 11, which will be reduced, about 20 to 30% reduction. Coming to the adhesive molecule, like the von Willebrand factor, will be upregulated, as well as microparticles would be upregulated. The anticoagulant, the natural anticoagulant, the protein C, the activated protein C resistance will be increased during the pregnancy, as well as the level and the activity of protein S, with the level of protein C remain unchanged. In the fibrinolytic system, you have the tissue plasminogen activator will be reduced, but at the same time, the plasminogen activator inhibitor type 1, which is derived from the endothelial cell, and the plasminogen activator type 2, derived from the placenta, will be markedly increased, and ultimately the fibrinolytic system will be increased. Although the tissue factor, the soluble tissue factor, remain unchanged during pregnancy, but the monocyte-derived tissue factor will be increased. This just shows you the summarization of the changes that occur during the pregnancy. And it has, as you can see, there is a procoagulant tilt in pregnancy. The interleukin 10 will inhibit the monocyte tissue expression. And the level has been found that the level of interleukin 10 are increased throughout the normal, healthy pregnancy. The lower level, in contrast, found in preeclampsia. Homocysteine as well has been found to induce the monocyte tissue expression at physiological level, and it is reduced during normal pregnancy. The activation marker seen in pregnancy, there will be an increase in thrombin activity, soluble fibrin level, increased thrombin antithrombin complex, as well as increase in the D-dimer, which is a sign of fibrinolysis. In one study, it has been shown that the coagulation and the fibrinolytic indices in healthy third trimester pregnant women were similar to or higher than those found in patients following DVT or pulmonary embolization. And yet none of these women develop any clinical symptom of venous thromboembolization. And this is just lead to the conclusion that the hemostatic changes during pregnancy is just as a physiological rather than a pathological process. On the same study, the fibrin peptide A to the ratio of fibrin peptide A to the D-dimer remained the same, constant throughout the pregnancy, suggestive of constant coagulation to fibrinolysis balance. In contrast to the high ratio seen in women with preeclampsia, which suggestive of hypofibrinolysis. So the balance in coagulation between the coagulation and fibrinolysis in pregnancy, the increase in the coagulation will be counteracted by the increase in fibrinolysis, and this lead to hemostatic balance during pregnancy. And any disturbance in this hemostasis will lead to the pregnant lady will be subjected to the risk of venous thromboembolization, and there will be inadequate maternal fetal circulation with all the complication associated with it, such as placental abruptio, fetal growth restriction, or preeclampsia. How the changes, the laboratory changes during pregnancy, during normal pregnancy, there will be endogenous, the increase in endogenous thrombin generation. Acquired activated protein C resistant normally increase in normal pregnancy, slightly decreased activated partial thromboplastin time, and increased the prothrombin time with INR less than 0.9. The platelet count usually within normal, except if there is gestational thrombocytopenia, as we're gonna see in a while. The platelet turnover is usually normal, and the bleeding time is normal. So these are the changes, the laboratory changes during normal pregnancy. Now, the complication during pregnancy could be, it has to be one of these three complications. It could be thrombocytopenia, bleeding, or thrombocytosis. And if the lady comes with thrombocytopenia, it has to be one of the four differential diagnoses. It could be gestational thrombocytopenia, immune thrombocytopenia, thrombotic microangiopathy, or acute fatty liver of pregnancy. And if there is bleeding, it could be primary or secondary postpartum hemorrhage, and in thrombosis, congenital or acquired thrombophilia. So coming to the thrombocytopenia, if the lady comes with only isolated thrombocytopenia, without any other symptoms, then the two differential diagnoses we have either gestational thrombocytopenia or ITP. Sometimes it's difficult to differentiate between the two conditions, but these are factors that could help differentiating both of them. The commonest cause of thrombocytopenia in pregnancy is gestational, with high incidence, 70 to 80%, as compared to the second cause of thrombocytopenia, which is ITP, 3% only. The explanation in gestational thrombocytopenia, it's believed that it's due to dilutional effect because of the expansion of plasma volume. Whereas in ITP, it is antibody against the platelet. Whether there is a prior history of thrombocytopenia or not could help in gestational thrombocytopenia. In ITP, sometimes the ITP onset could be prior to pregnancy. This will be helpful to determine the cause, but sometimes the onset during the pregnancy, and you wouldn't know. Now, the platelet count usually is very mild in gestational thrombocytopenia, with the count between 130 and 150, whereas in ITP, usually it's less than 100. The onset of gestational in the second or third trimester as compared to any time in ITP. Spontaneous resolution after delivery usually is the case in gestational thrombocytopenia, but not always with ITP. With the gestational thrombocytopenia, the fetus will not be affected, but in the ITP, the antibodies will cross the placenta and cause neonatal autoimmune thrombocytopenia. The management will be observation in case of gestational thrombocytopenia, and ITP, it's almost the same as a non-pregnant lady, with the exception of NTD and azathioprine will be avoided because of the safety issues for the fetus. Now, if the thrombocytopenia are combined by microangiopathy, hemolytic anemia, then the differential diagnosis will be one of the three differential diagnoses. Could be HELP, TTP, or atypical HUS. With the incidence more with the HELP syndrome. You know, HELP syndrome is a very severe form of preeclampsia, which is defined as a new onset of hypertension plus proteinuria after the age of 20 weeks. And the etiology of HELP believed to be the poor placentation of in the placenta, and both of the three cases will be presented with thrombocytopenia and have the elevated liver enzyme and low platelets. And the management for HELP syndrome, management of the pressure, and as soon as possible to take the lady for delivery, as the pathophysiology or the pathology in the fetus, in the placenta. The TTP, the treatment with plasma exchange, and HUS with eculizumab. The TTP السلام عليكم. انقطع الاتصال.
We can hear you now.
I can hear you.
Okay. Just carry on.
Okay, I don't know what happened. Is it lost connection? Did you hear me? Because I'm in the middle of my presentation, actually.
Yeah, it just
Can
for
I
a few
just
seconds.
continue, or
yeah, please continue.
Or,
you were just disconnected for a few minutes, for a few seconds. You can just
okay.
carry on.
So just continue. Okay, thank you very much. So with the HUS, the causative agent here is the congenital defect in the alternative pathway.
Can you share your
complement.
slides? Can you share your slides again?
Oh yeah, sure. Now you can see it, right?
Yes.
Okay. So the causative agent here, or the abnormality here in the congenital, the alternative pathway of the complement in acquired atypical HUS. Okay. The last differential diagnosis of thrombocytopenia in pregnant lady is the very rare and life-threatening condition, which is acute fatty liver of pregnancy. The incidence is not well defined, and it's variable through the literature. It is triggered by the microvasculature and fatty infiltration of the maternal hepatocyte, which lead to acute liver failure and result in the death of the mother and the fetus. The initial presentation is non-specific, the GI symptoms. With the disease progression, they will be characterized by significant liver enzyme elevation and sign of hepatic dysfunction, such as encephalopathy, coagulopathy, and hypoglycemia. The diagnosis is based on clinical and laboratory signs, and the liver biopsy is the last resort. Now the bleeding in 30% of death in the mother accounts for the postpartum hemorrhage, and it is defined as a loss of about a liter of blood. According to the onset of this bleeding, within 24 hours, it is called primary, and if it's between 24 and 6 weeks, it is defined as a secondary postpartum hemorrhage. The primary cause, usually it is related to the uterine atony, retained placenta, and genital tract. The most important primary hemostasis to stop the blood after delivery is the uterine contraction. And if there is abnormality, this will lead to primary postpartum hemorrhage. The treatment with oxytocin and uterotonic agent and recent randomized controlled trial found that tranexamic acid use after delivery will significantly reduce the risk of postpartum hemorrhage. The secondary cause of bleeding could be one of these conditions, either von Willebrand disease, hemophilia, or the other rare bleeding disorder. I tried to summarize all the causes. So we'll talk about the von Willebrand disease, which is the most common. About 1% of the population affected by von Willebrand disease. It has 3 types: quantitative type 1 and 3, and qualitative type 2. In pregnancy, represent a challenge for the diagnosis of von Willebrand disease, as you saw that the von Willebrand factor will be upregulated during pregnancy. And in type 1, as it is partial deficiency of von Willebrand factor, it can reach to normal levels. So it is very difficult to diagnose a lady during pregnancy for von Willebrand disease, and it's better to start the investigation after 21 days post-delivery, as the von Willebrand factor will be returned to normal. The treatment using the von Willebrand factor concentrate is the preferred choice, as desmopressin is controversial. Some try to avoid it as it causes placental insufficiency or hyponatremia in the mother, and other reported that they are using in routinely with no complication. In hemophilia, you know that it is X-linked. It's either deficiency of factor 8, hemophilia A, or factor 9, hemophilia B. And the female, usually they are a carrier. Because of the wide range of the level of the factor in carrier state, it's preferred to check at least once and repeat it close to delivery to check the activity of the factor. If it's less than 40, then consider the replacement with factor. And it's very important to determine the gender of the fetus, as 50% of the male for the affected carrier will be affected by the hemophilia. And it is important to decide the intrapartum management, or to avoid some, for example, the scalp, the forceps, or venous extraction. The other rare bleeding disorder could be one of these deficiencies, and the treatment with either fresh frozen plasma or factor concentrate. It's very important to recognize the deficiency on factor 1 fibrinogen or hypofibrinogenemia or dysfunction fibrinogen, as the fibrin is very important in implantation of the placenta. Now, the third complication, which is the thrombosis, acute venous thrombosis, could be pulmonary embolism or deep venous thrombosis. The pulmonary embolism in developed country remained the leading cause of maternal death, with an estimate 1 to 3 maternal deaths per 100,000 live births. The incidence of venous thromboembolism estimated to be between 0.5 to 2.2 per 1,000 patients, which is 5 times higher than the non-pregnant population. The diagnosis of acute venous thromboembolism is challenging because D-dimer is no more can be used as it's normally upregulated. So for diagnosis of DVT, use the compression ultrasound, and for pulmonary embolism, use the CT, pulmonary angiography, or ventilation perfusion scan. And the treatment, the therapeutic low dose, dose of low molecular weight heparin is a preferred choice during pregnancy, and has to be stopped about 24 hours prior to vaginal or cesarean section to allow for regional anesthesia, and resumed back 4 to 6 hours after normal vaginal delivery, 6 to 12 hours after cesarean section. The thrombophilia, which is the increased coagulation, increase the procoagulation or the tendency to thrombosis, it could be congenital or acquired. The congenital cause of thrombophilia, it include but not limited to these: factor 5 laden, prothrombin G deficiency in the natural anticoagulant protein S, C, and antithrombin 3. And it has been found that the inherited thrombophilia present in 50% of the venous thrombotic event that occur during pregnancy and postpartum. And the presence of thrombophilia does not always lead to the thrombotic event. Now, the acquired thrombophilia, unlike the congenital thrombophilia, which we can say it is relevant or it is equivalent to antiphospholipid syndrome, shows a poor pregnancy outcome, the association with a poor pregnancy outcome between the antiphospholipid syndrome and the poor pregnancy. It is defined, the antiphospholipid syndrome defined as autoimmune disorder characterized clinically by one of these: venous or arterial thrombosis, recurrent first trimester miscarriages, fetal death in the second or third trimester, or preterm birth due to severe preeclampsia or placental insufficiency, plus the laboratory finding, which is one of these antibodies, either lupus anticoagulant, anticardiolipin, or anti-beta-2 microglobulin. And it has to be measured twice, about 12 weeks apart. Now, for congenital and acquired, there is a difference in terms of antepartum and postpartum prophylaxis, the use of anticoagulant. For congenital thrombophilia, an attempt to quantify the relative risk, you have to quantify the relative risk of VTE, which considered to be the highest among those patients with homozygous factor 5 laden, prothrombin G, or combined heterozygous factor 5 laden and prothrombin gene plus the antithrombin 3 deficiency. And according to the relative risk, whether to use or not to use the prophylactic anticoagulation. Whereas in acquired hemophilia, the use of heparin, either unfractionated or low molecular weight heparin plus the aspirin, show a significant reduction in the fetal loss or the miscarriages. The use of postpartum thrombophylaxis in patients with persistent
2 minutes left.
Yeah, sure. Okay, I'm in my last slide actually. The use of postpartum prophylaxis with antiphospholipid syndrome is not clear yet. And there is a consideration to use postpartum prophylaxis with low molecular weight heparin for at least 6 weeks postpartum. Finally, I'll just talk about the screening in complicated pregnancy. For the congenital thrombophilia, it hasn't been shown, the guideline is not to screen for congenital thrombophilia, as a recent clinical trial showed that there is no significant effect with the use of antiprophylaxis to reduce the risk of VTE or the pregnancy loss. Whereas in acquired thrombophilia, it is recommended to screen with a history of complicated pregnancy. I'm ending with my presentation, and thank you very much.
Dr. Sameera Alsafwani, thanks a lot for the very brilliant summary about the obstetric hemostatic complications. We have one question for you. And the question says, what platelets count would you allow for delivery, and does it matter which condition and what mode of delivery for the count?
Okay, thank you very much for this question. The level for platelet, the safe level of platelet count is 30,000 for normal vaginal delivery. And if the lady going for cesarean section, it has to be 50,000. If epidural to be used, as you know, that there will be involvement of CNS, then you have to go higher, about 100,000 100,000 per microliter. Then the next part, which condition and what mode of delivery, it doesn't matter as long as you have a safe level of platelet count. It depends on the condition of the mother rather than the platelet.
Perfect. I think that's all. That's all for you, Dr. Sameera. Thanks a lot. And let's move. Oh, we have another question that just popped up. Is it useful to use the cryo to reduce treatment?
Well, the question is unclear. What does it mean? I think maybe something missing. Yeah, it's from Fahd al-Sharif. If you can please clarify. We still have time. I think he could be in the postpartum bleeding to raise the fibrinogen, if I'm not mistaken. Cryo for the treatment. For the treatment of which condition? Cryoprecipitate for transplant. To use FFB for what? Just to specify which condition you are talking about.
Yeah. We're still waiting. Okay, another question. Is there any role for prophylactic low molecular weight heparin in patients with recurrent miscarriages without evidence of thrombophilia? What do you think?
Okay, is there any rule for prophylactic in the use of miscarriage without evidence of thrombophilia? Well, I cannot answer this question actually. There is no evidence of thrombophilia, then they use just for blindly. I cannot answer that question actually. Maybe this is gynecologists need to answer you. I believe that some gynecology can use it. I have seen some cases they use it even if they don't have just the last resort. But I don't know.
I don't think this practice, even giving low molecular weight heparin or aspirin blindly for miscarriages.
In fact, this is not practice, but I have seen it in some cases.
Yeah, we see it a lot, but I don't think it's the correct thing to do. Okay. Dr. Sameera, what do you think in the terms of postpartum hemorrhage? What do you think is the minimum amount of fibrinogen would be, and is cryoprecipitate, does it have a vital role? Do you recommend fibrinogen concentrate transfusion to those
Fibrinogen for the
populations?
use of postpartum hemorrhage? I
Yeah.
haven't come across the use of fibrinogen. I don't know, actually. I cannot
Mhm.
answer this question, but the tranexamic acid, which shows the significant reduction of the risk of bleeding postpartum. But the fibrinogen in the without hypofibrinogenemia, you mean the lady doesn't suffer from deficiency, or she doesn't have dysfunctional fibrinogen? What is the use of fibrinogen then? I don't think so.
Okay. Yes, maybe it's good to highlight the latest NEJM study, which has used the prophylactic tranexamic acid to prevent postpartum bleeding for ladies who underwent cesarean section. Okay, we have from Fahd al-Sharif. He sent again. If the patient needs to transfuse or diagnose with ITP, which one is good to use for the transfusion of platelet or cryo, reduced plasma or platelet in order to prevent bleeding? Yeah, in the transfusion for patients in the setting of ITP, what's your recommendation?
Yeah, and the setting of ITP, you mean a pregnant lady? If he's talking about a pregnant lady, I think, right?
Yes, yes.
Well, the treatment in pregnant lady with the steroid, low dose steroid, and IV immunoglobulin, and the platelet transfusion only if there is bleeding. Because it's ITB, you don't give just a blood transfusion, platelet transfusion, and there is autoantibody which will be destroyed. If you don't treat the cause of thrombocytopenia, which is the antibody, you have to use the steroid. The critical issue here, or the significant treatment, is with the use of steroid and the IV immunoglobulin, not only the platelet transfusion. Platelet transfusion only if there is bleeding. The patient is symptomatic and she has a bleeding. And with the use, of course, of a steroid and immunoglobulin. And if there is refractory, it's refractory, then they can go for splenectomy and other more advanced treatment with the ITP.
Yeah.
I hope that answered.
Okay, Doctora,
yes,
we have to
let's move to the next speaker.